Hello and welcome to the Ascend Health Show. I'm your host, Nick Angelis. I'm a nurse anesthetist and the owner of Ascend Health Center, and I'm here with Dr. Whittaker from Custom Care Rehab. How are you today?
Hi, I'm good. How are you?
I'm great. I almost started the show with, ouch, are you in pain? We've got Dr. Whittaker here. But I always hate those gimmicky type of podcasts, so I figured I'd be a little bit more normal.
That's fair.
Too late. I'm not normal. This is terrible. So why don't we talk about post-operative pain, because that's something that at Ascend we have this strange, I guess streak is the right word, where now that we've been in business for 6 years, there's probably been about 40 or 50 of my patients who've had surgeries, and all of them have had excellent post-operative outcomes. So now again, these are patients who are getting IV infusions, ketamine, Spravato, different medicines that really help with inflammation. So that's why their post-op course has been uneventful. But physical therapy is, of course, something that people often think of I had to get my shoulder replaced or I had a knee operation, and then, I had to fight for my insurance and they gave me 3 visits with a physical therapist.
Yeah, so with postoperative pain, we can often control that really well if somebody does what we call prehab. So we have physical therapy before you actually have the surgery. And so it just helps the muscles be strong. It helps the patient kind of understand what they're getting into for after surgery, after their rehab. And so that you're setting yourself up to have surgery at maybe a B rather than at the D that you feel. And it kind of gets them again in the same mindset of, okay, this is what I can kind of expect. It's going to look very similar. And then so after they have the surgery, they're in the right frame of mind of, okay, I've done PT before, I know what it's like. And then they can kind of go back to the exercises maybe they have already done, but we're starting from zero now.
Right.
And so it helps with the outcomes very much.
Wow. And it probably helps with injury prevention too, because they know, okay, this is the range of motion that's normal for me before I had this operation.
Yes, and it's really helpful so that we can teach someone how to use their stability muscles and their supporting muscles versus those big movers, so that we can support the joint itself versus having to rehab that after surgery and kind of fix those habits then.
Sure. So that way you avoid overcompensation where one muscle group is being used all the time and then another one isn't.
Exactly.
Which is fine until you need to make some sort of sudden movement. Like right now it's winter in Ohio. This is the orthopedic surgeon's busy time because everyone's falling on the ice and breaking things. So, and a lot of times those falls are because the muscles aren't stable, they're not working together, one is overused, one is underused, and you can't catch your balance.
Yeah, and so sometimes people are just surprised and everybody falls. Like you might not fall and then you hit that ice and then you slip, and so we do see a lot of people who maybe have concussions, and so we treat them, or if they've hurt their ankle or their shoulder from falling, we treat that as well. But then if it is a true balance issue, we can help them with their balance and make that better too.
Yeah, I think this is my 64th show or so, and around show 30-ish, I had your partner Amy on here, and we talked about dizziness and balance and how useful that is, because as a rehab place that can come to the patient, if you're dizzy, you don't want to travel to a physical therapy's office to go work on your dizziness and your balance so that you don't fall. So
yeah, I've worked in clinics where we have multiple people working at the same time, and often those vestibular patients have to have somebody drive them, and they don't want to leave their house, or they're worried about the ice, they're worried about what they can encounter. They don't want to shower by themselves. They just always have to have somebody there. And so it's helpful for us to just come in there and also kind of assess what their home looks like and help kind of fine tune some things and of how to make things easier within their home too.
So you can actually do a home visit where you're saying, okay, this could trip you in a week, or let's remove this rug, or oh wow, that's really useful.
Yeah.
Yeah, I've noticed that too when referring patients to you guys, that it is something very helpful, because a lot of times the mental health and the physical health are so intertwined, and it may start with a vestibular problem, but then it becomes an agoraphobia, or I just have to stay here where I'm safe.
Absolutely.
And the obsession of being safe can lead to a really unsafe place for their mind, basically.
Yeah, fear avoidance is a huge part of what we do, and so working with chronic pain, I work with that a lot as well, and just trying to teach someone how normal activity is okay to do, even if it was once painful, and trying to help them work through that. And sometimes it's not even that they physically can't do it, they just, in their brain, they've convinced themselves that they are unable to do it because they're so fearful of what might happen.
Right. So you're saying the old idea of pain mean stop? In some cases, it's like, no, there'll be more pain if this muscle atrophies because you're not working through this pain.
Yes, more pain, more stiffness. I usually tell people non-painful range of motion versus like limiting their range of motion. So go as far as you can, but if it feels just kind of stretchy, it's a little bit uncomfortable, that's okay. But if it's a sharp pain, if it's numbness, tingling, anything like that happens, we need to not go into that range of motion just yet. So we don't have to rehab more than what we need to.
Oh, that makes sense. And that's where my problem would be. So Monday for me was basketball. Yesterday was pickleball. Today is volleyball. And unfortunately, the rule is that I'm not allowed to complain to my wife about how sore I am since I'm in my mid-40s and playing all these sports like I'm still 20. Like, that was our agreement. Like, okay, you can play all these sports. That's fine. You can pretend you're 20. Except for the one time I got a concussion, but that's a longer story. But I'm not allowed to complain about, oh, why does my ankle hurt? It's because I played full court basketball for 3 hours and I did no other exercises that week. That's what it is.
Yeah, the weekend warrior. I'm assuming you're doing this through the week, or are you doing it all on the weekend?
In this case, it's, let's see, today's Wednesday, so Monday, Tuesday, Wednesday.
Okay,
So,
yeah. The weekend warrior. So when people just do exercise on the weekends only, we do get injuries from them too, just because maybe they don't warm up, maybe they don't cool down, and then they're sore. But as healthcare providers, I think we're often the worst patients.
Sure. And you all watching thought this was so that we could learn some more about physical therapy, what Ascend does. No, this is for my own use in case I need the prehab and the post-hab and the intermediate hab.
Well, we got you.
Oh, good. So I assume that insurance would not pay for any sort of prehab things, correct?
Some of them do. So Amy is mostly self-pay. She does do some Medicare, and then we can give a super bill so that we can have that paid for. And you can just kind of see if your insurance will cover it.
Sure.
Sometimes if you have pain, and then you are able to get that covered, and then it might just be, okay, we're just trying to prevent surgery. And so sometimes insurance likes that. They have to pay a little bit less to do the PT versus having to pay for the surgery. So sometimes you can get it covered. It really just depends on the insurance. But for my place of work, we mostly do self-pay and then Medicare.
Right. And the advantage of that is what I felt, because we did a show recently where we talked about the big, beautiful bill. And the takeaway was, honestly, for a lot of our patients, like, maybe just look both ways before you cross the street and don't get insurance because it's not going to help you anyways, which is a terrible, cynical thing to say. In fact, I had a few patients say, that was harsh. And then I had to think, oh, the part of the problem is that I'm here talking to another professional, so it's not customer service patient speak. It's like, here's how things work speak.
Right. I enjoy the self-pay a lot. I have worked with insurance, and I've worked in like a high volume clinic before. And it's really nice to know that if somebody has, like, for example, low back pain, but over the weekend they fall, they sprain their ankle, if I were working with insurance, I couldn't treat the ankle. I could maybe give them an ice pack, kind of tell them verbally what to do, but I couldn't bill for it. I couldn't treat it. I would have to have them either, if we were in a place of direct access, we could then, I could then maybe open a new case and treat that, but then I wouldn't be able to treat the back. And then then I could ask them to go get a referral, but then it might be 2 weeks, and then I can treat the ankle. But with self-pay, I can just treat it, and I don't have to worry about it, and I can tie it in with what we were already doing. So it just helps me treat my patient with what they need and treat them like a person versus trying to play the insurance game of pleasing them, but also doing what's best for my patient.
Because to be honest, that scenario sounds ridiculous.
No, it breaks my heart every time. They're like, really, you can't do anything? I'm like, I can't. I can give you some ice and I can tell you what to do, but I can't treat it here. We can take it easy, not do standing exercises, we can modify, but I can't actually treat the ankle and bill for that. And at Ascend, most of what we do is insurance-based, but the ketamine infusions, injections, that sort of approach is self-pay, and so that's how we use it. So it kind of annoys my front desk, but there's patients where I'll just say, come in tomorrow at some point, and then we'll talk, and then we'll figure out what we're going to do and what you need, and then we go from there. So I don't even know, and they don't even know what they're coming for until we have a discussion, see, okay, what's the most pressing concern, what needs to be treated today, and then we treat that. Because the other way is, because it's really helpful now in Northeast Ohio, once in a while, either Cleveland Clinic or UH, one of these hospital systems will provide ketamine infusions for patients so that we don't have to, take self-pay for that, but there's a long way, it's very specific. So the ability to get treatment exactly when you need it Yes.
And I feel that most things you can put a price on, and that's how healthcare should work. Like when I go to a restaurant, okay, nope, this is too expensive. I don't want these cheese sticks.
Yeah.
I just feel it empowers patients to realize, okay, this is what will happen if I pay this much.
Yes.
And then we're done with this transaction. There's not 4 calls to an insurance company.
Yes. And as a physical therapist, I think if you talk to anybody, we want you to be as independent as possible. So like my goal, I do a lot of patient education so that the patient feels empowered on how do I treat myself? How do I understand what's going on? How do I do these exercises so that eventually when you feel ready, when I think you don't need me anymore, you can do your home program by yourself and we'll kind of wean you off the therapy. And then if you need like a once a month tune-up or every couple months tune-up of like dry needling or manual or whatnot, we can help you out there. Or if you get hurt again and it's not the same as what it was before, we can help. But I want them to be as independent as they possibly can, because you can't take me, well, I go to your house, but you can't take me home with you. I'm not living with you 24/7.
But again, that is more empowerment. The idea of you can see me more often, or you can do your homework and see me less often, and there's no shame in either approach.
Yeah.
It's just that you have a choice in this, and that's
Yes.
so gratifying, I think, for people in the healthcare system, where so often it's like, nope, sure, it said we could do that. No, we can only do this.
Yes.
That, hey, this is up to you, and it's fine if you can't do this part, but at least this way you can see our faces less often.
Yes, absolutely.
Wow, that's great. So you mentioned dry needling. What do you use that for mostly?
So oftentimes it's if somebody has a tight muscle, it uses acupuncture needles. So I buy acupuncture needles to do it, but it's not surface level. We're not doing chi, anything like that. We're putting the muscle or the needle directly into the muscle, basically to hit almost like a reset button. It makes like a little bit of micro damage like you do with exercise. So when you exercise, you have a lot of tears, and then your muscle rebuilds stronger, and that's how we get the hypertrophy of the muscle.
Right.
With dry needling, it's like hitting the reset button, allowing it to kind of go back to the position that it is supposed to be in, so that we can then re-educate it with exercise. And then also we can use it for actual muscle re-education. So if someone has torn ACL, they just had surgery, the hardest thing to do is get the quad back. And so we can do dry needling, put stem to it to try to get that brain muscle connection back so that we can even use the quad properly.
Wow.
So we can use it for a variety of things.
And sometimes with injuries, it does take several different providers to get that. Like we were just talking about peptides with a chiropractor and a nurse practitioner. And a lot of what we do at Ascend is sending patients to various places so that cohesively they can get the full approach.
Yes.
It's kind of ironic because a lot of times we'll have patients who go to multiple specialists and there isn't that cohesiveness. It's just like, okay, we're looking at your kidney, okay, here's how your eyes are doing. But I think a lot of times when there's a personal relationship between different providers, we can better curate, okay, here's what the next step is.
Yeah, I once had a instructor to say to a patient, because it seemed like they were getting so many different answers. They're like, well, if you sit a chiropractor, a primary care, and a PT in the room, you're going to get 5 different things said what's wrong with you. So it's nice when we can all just communicate so that we can just take care of the person sitting in front of us. And I have noticed that a lot, and it's been wonderful.
Right. Yeah, and sometimes it is, okay, we have to drill down to the root cause. And sometimes it's the other approach of like, okay, here's a symptom that's bothering you. We need to fix this before we can go anywhere else. And I think that does take a lot of conversation with the patient of, okay, what can we tackle most effectively?
Yes, it does. It does. And so like, and of course, there's some things with PT where you just get at a standstill, and maybe I do need help from another profession so that they can just take care of one thing, so then we don't plateau, and then I can come back and like finish out the PT. And so there has been cases like that. So it's just nice to have those connections to kind of hand off, and so that we can keep in contact with that person.
Yeah. My classic example is I had a patient who had a lot of, they weren't neuropathic injuries, which is what we treat mostly with the ketamine infusions. So I was unsure if the ketamine or PT would work better. So I had him come to us, have a ketamine infusion. Right after that, once he recovered, he went and did PT. And I said, you won't need both of these. And we decided afterwards, like, no, I think the PT was actually more helpful than the ketamine. So I didn't see him again. He went to PT and got better that way. So sometimes it is nice to almost have a rock, paper, scissors competition of what's actually going to help you the most. Let's go with that and continue that path.
Yes.
Because sometimes there's too many options, I feel, for patients.
There are.
So.
There's almost like I've definitely had patients who are on so many different medications, so many different, seeing so many different people, and I was like, okay, well, let's try to cut down a little bit of this so we can kind of even see what is working and what is not, because sometimes you just kind of muddy the waters a little bit and you can't see what's truly making the effect for that person.
Are there common PT misconceptions? Because again, the American healthcare system is almost completely, here's a pill, take a pill for that. Oh, you're feeling that way, here's a pill for that.
Yeah. Yes, I think one of them is that we just do a lot of like stretches and things like that. Sometimes patients are a little bit upset that I ask them to do exercises, or I have to really educate on the buy-in of exercises. They're like, well, I've had this pain for 20 years. And how is this even going to help me? All we're doing is stretching and exercising. I'm up on my feet all day. I was like, well, it's exercising with intent. And so you may have been exercising up on your feet, but maybe you're not targeting those little stabilizer muscles that maybe you don't even know about because you aren't a PT or you haven't had someone educate you on that. And then the prehab one is the biggest one. So thinking that you can only have PT if you have an injury, and that's not true. We get people who, for example, if you're on a sports team and we want to prevent ACL injuries, well, then we can rehab you there too. If you do a very laborious job, we want to prevent you from having overuse injury, so we can prehab there. If you're wanting to prevent surgery and this is like your last ditch effort, if you have a rotator cuff tear, I've had people who have come to me with rotator cuff tears and they didn't have to have surgery because we got them to a manageable place. They were able to do everything they wanted to do, and they're like, well, I'm able to live like this. I do not want to have surgery, and so we're able to prevent that as well.
And I think, so a lot of times that's the crux of it, is the decision making of, am I bad enough for surgery? And it's very difficult. For our patients, a little easier. I'm a nurse anesthetist. I might work on them once a week for several weeks. Hey, you're still not at a place where you're comfortable. If I can't help you, then you need surgery. And that way they also, again, these in many cases have anxiety, depression. They can go into the surgery with more confidence, knowing, okay, I had somebody who knows this stuff work on me for a while. It did not go away. I can, with more certainty, go to the surgery knowing like, okay, it's time for this.
Yes.
So.
And it helps with that too. It's almost like you become a little bit of a mental health therapist versus like a physical therapist with people who've had chronic pain. And it does. It gives them the confidence to know I did everything that I could. But I am better than what I was off. But I do need that surgery. And so sometimes you just have to. And but we work together, and then I'm always very honest about it. If I think that you've plateaued, if I think that there's nothing more I can do, I help you get to where you need to go so that they can get you even further than what we got.
Sure. And in many cases, so we started in 2019, I did a lot of pain management at first with ketamine infusions, and then I slowly realized, if I use smaller doses and at least take care of the anxiety, then it's a lot less work for the patient, a lot fewer visits, and then we can send them to PT because now that the anxiety and the depression's gone, they are actually much more enthusiastic about the parts that they can do, where before I said, no, I've tried that, nothing helped. But with that new mindset, they can actually make some progress. Yeah,
that's definitely a really challenging part of our job, is with people who have anxiety and depression, because that intensifies pain. And so trying to help someone have the motivation to do something when your motivation's already decreased is very difficult. But I always try to just educate that exercise is one of the best medicines for that. It helps just get the endorphins flowing. And especially with chronic pain and depression going hand in hand. And then it'll help with surgical outcomes too, if we can get you moving a little bit more and make them feel better.
So is there a specific way that PT helps with pain? I know you mentioned endorphins, which a lot of times, like you said, they won't flow unless you're moving, unless there's some sympathetic nervous system response from the body.
Yeah, so PT and pain, we do a lot with that. So it's almost, a lot of what I do is verbal education almost when it's pain, because pain is very different for everybody. It's very a mental thing. And so there's, for example, if you've ever like stubbed your toe and you didn't see an injury, like you stubbed your toe and it was fine, but then you look down and you're bleeding and then it hurts so much. You didn't know that there was an injury there, but there was, and you didn't realize it till you saw it. We have to basically re-educate somebody's brain on how to get their alarm system reset. So I like to use the example with my patients for the Ring camera. People get those because they want to see intruders, but they also tell you when your spouse is there, when there's a squirrel. And so the spouse and the squirrel are like the normal everyday things. And so our bodies are registering the spouses and the squirrels or the normal activities as pain, as injury, as danger. And so we have to get them to understand that pain does not equal injury, and re-educate them that normal activity is okay. And so it's a lot of talking through things and a lot of like coaching on tissue healing is 6 to 12 weeks. It's already healed. Now we just kind of got to push through this, and we have to understand that doing normal things is not painful. We're not doing extreme things that's going to put you at risk. I wouldn't ask you to do that. So it takes some guidance, a lot of guidance with that, and educating on the pain system, and that it does not mean injury. It's just a warning.
So sometimes it is, oh, I never healed from this. Well, maybe you did. You just didn't realize it. Yeah.
So it's not that they never healed. They have healed, but their brain is still registering nociception from that area. And so nociception is the signal that your body sends that what we register is pain. And so it's just like your body's just on high alert in that area. And now we kind of have to get it to remember, like, okay, no, it's actually fine. Like, we don't have to guard so much. We don't have to make those muscles so tight to protect it. We can let it breathe, let it relax, and bring down that alarm system that we only register intruders. That's just a squirrel. It's fine.
No, that makes sense. We deal with a lot of autoimmune disorders. And for years, specialists said you cannot feel itching and pain at the same time, like with psoriasis, psoriatic arthritis. And then they realized, no, like both of those will simultaneously go up your spinal column into your brain, and that's how your brain will register it. So sometimes it is distraction. I mean, I'll put in IVs every day at the clinic, and sometimes I'll ask the patient, what's your second favorite color, as I'm poking them with an IV needle. And just that part of their brain, like, well, wait, my favorite color is red, obviously, but my second favorite color, no one's asked me that since I was 7. And then by the time they come back with an answer, the IV's in and they're done. So, and I feel that especially when we deal with mental health, it's perfectly fine to trick your brain. Your brain's trying to trick you and tell you you're sad when there's nothing to be sad about. So return the favor.
Yeah, we do that a lot as well. So like different facilitation techniques, or like tapping on something if we're working on it. So like I'm working on your knee, so I'm tapping your thigh, trying to make sure that you're focusing on that, not what I'm doing at the knee. Or if we're doing balance stuff and somebody's fearful, I'll talk to them and we'll just talk about things that make them happy, so that maybe they're focusing on that versus the fear of falling. So just trying to help them, basically distract them to get them to a better place.
It's really fascinating how much the physical therapy you're talking about is so similar to the psychotherapy.
It is. I have to draw the line sometimes, because some people, it's almost like being like, you always hear women talk about hairdressers, and like you hear all the gossip, you hear all everybody's secrets. It happens the same with physical therapists, because we're a healthcare provider that spends one-on-one time an hour with you. So we get to know our patients very well. We get to know their story very well. And so being able to understand, like, okay, this is now outside of my scope of practice. We're not talking about pain. We're not talking about fear avoidance. Now we're talking about things that are serious issues. We need to get you to this person who can now help you. And I think that would be helpful. And so we also have that trust with them to where they'll value our opinion very well, because we've worked together like for weeks at a time, an hour together by ourselves.
And they know that you actually know them. This isn't like, okay, we talked for 3 minutes, here's another specialist. Okay, wow. Because you're right, so emotional tapping technique, or there's a lot of different ways that, even as we're dealing with trauma, that we can distract people as they go back into the subconscious or relive something. So that is really fascinating.
Yeah, it's a new thing that is kind of coming out in PT schools, because they didn't used to really talk about pain neuroscience as much as what they do. They did a class on it, but I know I went to Belmont University and they are very big on it, because they teach us to treat our patients as a whole. Like, we're not just like, we are musculoskeletal, and that's what we are experts in. But our brain controls all of that. So we kind of have to understand what that is doing, and how depression and anxiety can affect pain, and how lack of sleep and all these other things can affect our patients, because they are people. They're not just knees and shoulders.
Well, that's great. So if someone watching today is interested in contacting you or seeing if like it'd be the appropriate treatment for them, what steps should they take?
Yeah, so I work with Custom Care Rehab. I believe my name and then the number is on the screen, so you can reach out there. And then I will kind of talk with you, see what's going on, see how far you are, because we are a mobile physical therapy place. So I come straight to your house, or I have come to people's works as well if they're very busy and they have a lunch hour and they need me to help them and they have their office. We go there. and we'll talk about what's going on. I will likely send you to Amy McMillan, who is my employer. She owns Custom Care Rehab, and she'll kind of help get your account, everything set up for you so that I can come out and see you. And then if you're not in the area that I work in, or if you're not close to me, we do have four other therapists that are in different areas that can come out and see you.
Wow.
Yeah.
Yeah, and I've sent patients to you guys many times, and that is, again, we have the same philosophy of sometimes we need a long-term relationship with the patient, but it's nice to have that as an option. And often it is because, okay, insurance paid for 4 visits, you need something else. So it is nice to be able to go to a place and then not feel that, okay, here's where I'm going to be forever now. So that freedom, I think, is so important for patients to know I can go somewhere, get what I need, go back if I need it.
Yeah. Yeah, so we usually have visits in packages. So we have like we can just do an eval if that's what it calls for. And I'm like, okay, I don't know if this is necessarily appropriate. Then I'll likely give you some treatment exercises and then send you on your way. But then we also have 3 visits, 6 visits, 9 visits, however you want to do it. And then I give my recommendation off of what we talked about during the eval, what I think is wrong. And then often we'll tell them, I see my patients with this company once a week. Usually I will have some twice a week people if they're post-op patients. And then I wean them off of their visits and let them know that at this time we need to space out the visits because you're getting more independent. I think we're in a good place. And then let them know we can just do a once a month if you want to, or you have my number if you need me.
Wow. And for us at Ascend Health Center, we're in Fair Lawn. We do some virtual visits, but the first ones are always in office. So we do have psychotherapists who, again, do a lot of the same things you do, just without moving quite as many muscles. And then usually the first step is you'll see a psychiatrist or a psychiatric nurse practitioner. Often they'll refer them to me, the nurse anesthetist, especially if it's a complex case of anxiety with pain, a lot of autoimmune issues, because a lot of those just, again, roll into each other into some sort of difficult to unwind tangle. So yes, we get a lot of people who have Parkinson's or multiple sclerosis, things like that, and so it's kind of just a teamwork effort on helping them get better. Absolutely.
For sure.
Well, thanks for coming on the show today.
Thank you for having me.
You are watching WCTV, Wadsworth Community Television.